All right. Good morning, everybody, and thank you for joining us for this morning's webinar, Living Kidney Donation Update. I have just a few housekeeping slides to go through. So we are the Kidney Foundation of Ohio. We service 32 counties across Ohio with broad-based services, including direct assistance for kidney patients and providing education programming to the general public, such as today's webinar. We remain one of the only health and human services agencies in Northeast Ohio that continues to provide direct dollars to patients to assist through the devastation of kidney disease. The foundation remains an Ohio-based program, and all the funds we raise goes to our patients here in Ohio. Today's webinar will last about an hour. You must attend the entire hour to receive credit. Questions can be submitted in the question and answer tab as all of you are muted. And if time permits, we will try to get those questions answered before the conclusion of today's webinar. And for upcoming events and other webinars, please visit our website at kfohio.org. So just some disclosures. There's no one with relevant financial relationships with an ineligible company, except for Amy Hazel, who is our nurse planner through the Ohio Board of Nursing. She is on the Speakers Bureau for Fresenius, Renal Pharmaceuticals, and Akebia. And Dr. Axelrod, one of our presenters, he has a he is a consultant for CareDx, uh, Specialist Direct, BMI Organ Bank, Bridge to Life, and Memo Therapeutics. These relationships have been mitigated. Participants, again, must complete the full time, and then there will be an evaluation which will be emailed to you after the presentation. Um, we ask that you complete that evaluation by December 19th, and certificates will be emailed out by December 19th via email. Kidney Foundation is an approved provider for continuing education through the Ohio Nursing Association and Ohio Board of Nursing Approver. Kidney Foundation is approved by the Ohio Counselor of Social Work and Marriage and Family Therapist, and this CE activity has been approved by the American Board for Transplant Certification, grants one continuing education point in Category 1 for transplant certification. This webinar has no commercial support. So at this time, I am going to go ahead and turn this over to Dr. Jody Jones, Dr. David Axelrod, and Melissa Putich, one of the transplant coordinators at University Hospital.
Thank you, Jennifer, and thanks all of you for participating in this. Because the focus of today's talk is about asking for living donor, what we wanted to do is sort of bookmark the entire presentation, starting off with sort of a personal vignette about it, and then we will return to that with the parts in between, talking about what makes a person eligible for living donation. Dr. Axelrod is going to be joining us sort of briefly here in the start. He actually has to go and do a living donor surgery. So I'm just going to start this off, and then we will turn it over to him. So my story begins a long time ago. The Jim, who you see here in this photograph, is my cousin, and he lives in Des Moines, Iowa, and has long been a bicycle fanatic. He actually had a very popular bicycle store in Des Moines for a long time. About 20 years ago, he was informed that he had really serious hypertension that was damaging his kidneys. I don't know that we ever thought that he would potentially get to the point of transplant, but he made some really significant lifestyle changes at that point. In fact, he adopted a renal diet and which he followed for 12 years prior to his actual transplant, and he was never actually on dialysis, which is amazing. That's an early picture of me. I also is a very much into bicycles and have been an outdoor cyclist for many, many years. And so when I found out that potentially he was going to end up needing a transplant, I discussed with him, since I am a transplant psychologist and have been working with a number of different transplant programs for a number of years, what the plan was. And he originally had not really been seriously considering transplant and was pretty uncomfortable with the idea. I encouraged him to come and get evaluated at University of Iowa Hospitals, which is where I was working at the time. And so as you guys have probably known a lot of potential recipients who are really uncomfortable with the idea of having someone donate a kidney to them, he really did not want me to pursue this at all. I had to really sort of pursue it myself, almost independent of him. I asked him if he would just be okay with me going ahead and starting the evaluation to even see if I could be eligible as a donor for him. As he was getting closer to the time where he was going to actually need to start dialysis, kind of opened his mind a little bit more to it. And so I did go ahead and start the evaluation. And if you want to go ahead and forward the slide and go ahead and bring up both parts. There you go. So I was approved to be a donor, and this is just a text message that I had sent Jim's wife, Kathy, on the morning that I found out on October 11th. The donation was set for December 13th, so the 7-year anniversary of this is in just a couple of days. One of the things that I hadn't really fully appreciated about my offer to donate was how much it was not going to just affect Jim, but his entire family. His wife, Kathy, had been so anxious about him starting dialysis. They were going to do peritoneal dialysis, and she was so skittish about this. Sometimes we forget that our dialysis patients, it just affects the entire family. It's really such a profound and difficult experience for people to go through. So the transplant did happen. If you want to go ahead and forward the slide. And this was us on December 13th. I was able to go in and see him the evening of the transplant. It was a lot more difficult than I had anticipated, and some of the things that we'll be talking about later in this talk will reflect some of the experiences that donors do have. It's a crazy sort of thing because people are calling you a hero, and you feel like total crap while you're going through this. It's like, I'm not feeling heroic right now. This is a pretty miserable sort of physical experience, but I have absolutely no regrets. You have to just get through that initial rocky stage and then get to a place of healing. And, to our delight, the kidney started working immediately for him, and it turned his life around. It was just really amazing. So what I'm going to do is turn it over to Dr. Axelrod. So Jen, if you want to go ahead and bring up the next slide. This is just sort of an overview, and then we're going to forward all the way up into, keep going. Oh, there you go. Yeah, the overview, basically, this is all we're going to be discussing today is providing some background, some medical, surgical issues, the actual procedure, and then we'll go back to psychosocial aspects of this. So we thought Dr. Axelrod was going to be late this morning, so we had moved all the slides up. What we're going to do is forward through all the psychosocial pieces and just go to where Dr. Axelrod starts. So.
Well, as usual, it's always hard to follow Jody because it was an amazing story that she did, and I think it gives us an incredible amount of.
Go ahead and keep forwarding.
Yeah, keep going. We'll let you know when to stop. There you go. Stop there. An incredible amount of insight as we evaluate living donors, as very few programs have somebody who's actually lived through it themselves to talk to people. So I'm going to talk a little bit about it from the surgeon's perspective, and I apologize for being in my surgical jammies here, but I'm actually running to the operating room to help one of my colleagues with a living donor. So why do we accept living donors? Because as we all know, there's not enough kidneys to go around, and we continue to suffer unnecessary people dying on dialysis. And if you look at the data, less than 25% of patients receive a deceased donor kidney at 3 years, despite the fact that we're doing more and more deceased donors than we've ever done. And I think, living donation is the way to bridge that gap and to get the best outcomes for our patients. Next. Living donor kidneys have significantly better outcomes. If you look at the patients who are surviving after about 5 years from transplant, if you look at dialysis, it remains about 40%. If you look at living donation, it's about 87%. Some of that is because living donor kidney recipients tend to be healthier than people getting deceased donor kidneys, but a lot of it has to do with the organs. The organs are healthier, they work right away, and very importantly, we don't end up having to wait for patients to have dialysis and the impact that dialysis have on their cardiovascular and other systems. Next. And yet, we realize that the living donor transplant represents the vast minority of people who have a solution for their ESRD. And thankfully, you guys spend a lot of time taking care of people. In that left-hand column, more than 70% of patients with end-stage kidney disease are being managed on dialysis, and only 10% of them undergo living donor transplant. And we think that that's an opportunity for us to grow that around the country. And we'll talk a little bit about the strategies you can do that for going forward. Next, please. Living donor kidney transplant is seen as the best treatment option for almost all patients with late-stage chronic kidney disease. And this is an international consensus. And it really reflects the fact that living donor kidney transplant allows you to be transplanted when the patients are most healthy, with the best organ they can possibly have, and the one that's least at risk for rejection and long-term complications. The issue, of course, is that the living donation has to be balanced with the potential risk of that donor. So that's what we want to talk about for the next couple minutes. Next. Most of you in the world of kidney disease should be familiar with the Carrick brothers. The Carrick brothers were the first successful transplant that was done in the world. It was done at the Brigham in Boston in 1954. These are pictures of them. And Joe Murray, who won the Nobel Prize, actually plastic surgeons he did the first transplant, said the major issue that we have to deal with here is the ethical decision of removal of a healthy organ from a normal person and what that risk is versus the huge benefits for the recipients. Next, click. The good thing is that this transplant worked well, and the donor lived to about the age of 80. And so we know, and I've been answering this question for about the last 25 years of doing donor. And, I said we've been doing this now for nearly 70 years, 75 years, that we know that kidney donation, when done ethically and carefully, is a safe and effective procedure. Next. So how do we balance this? We look at the donor risk, specifically medical, surgical, and we're going to go back and have Dr. Jones talk about the psychological and financial, and the benefits, which are very clear to the recipient and also to the family. And I think, as Jody mentioned, we are not often just treating a patient. There's no doubt the patients are better off when they have a living donor kidney transplant, but often the families are better. And especially, we see that, husbands and wives are able to travel and be with grandkids and doing all those sorts of things. So sometimes I do point that out to people who are reluctant to take, for example, a kidney from their kids. And I say, if you're the grandfather that's at your grandchildren's, sidelines and cheering on their sports and being there, it's not just you that your donor is helping. It's, his or her entire family. Next. The evaluation for living donation is comprehensive. This is a picture of the transplant team here at UH. It's an accurate representation, as you can imagine. You are evaluated on a single day by the surgeons, the nephrologists, the clinical psychologists. That's the good-looking one there. In the picture, social working, Jennifer Putich is our living donor coordinator, who's really sorry. I see Melissa Putich. I saw Jennifer next door and I'm living, is our living donor coordinator. We also have an independent living donor advocate. That's a requirement for federal policy. That is an individual very familiar with donation, but not affiliated with the transplant team, that exists particularly to make sure that we are respecting the donor and the donor wishes and to make sure that there's no evidence of coercion. We do a significant amount of lab testing to tell your donors this is all paid for by the transplant program. It includes blood tests and urine tests. We do chest x-rays, EKG, and I'll show you an example of a CT scan. There are some additional testing that is sometimes done. It's important to note if we find something that's medically an issue, so we require them to have a mammogram, that's standard medical care. They should get that paid for by their local insurance. And if we find breast cancer, we're obviously not going to pay for it. But there are other things, so we want to do additional genetic testing on them because it may reflect the chances that they could pass a disease along or something like that. That's something that the transplant program could pay for. We want to be sure that patients are protected financially, and we'll talk about that, and Melissa can give you some additional details. Next. The goals of the evaluation, first and foremost, we have to make sure that they have adequate kidney function. We are going to be removing one kidney. It is important to recognize you don't actually lose half your kidney function over time. You lose about 25 to 40% of it because your other kidney will grow and take over a lot of the function. We look at the renal anatomy. So patients are born with various numbers of arteries and veins going to the kidneys and that sort of stuff. Historically, we were pretty limited. We would take one artery, sometimes two. Now, as people have gotten more comfortable with these, we're taking more and more anatomically complex donors and still doing them laparoscopically or robotically. We ensure that the risk of disease transmission is low when we assess high-risk behaviors. It's important to know that we do need to disclose high-risk behaviors and other things to a recipient. So, if somebody is, for example, doing something that we think potentially puts their recipients at risk, we give them the option of either backing out of the donation or having us disclose that. For family members and things like that, that can be tough. And I think, again, it's one of those psychosocial things to discuss. Obviously, you're tested for various infectious diseases and malignancy. We have to assess immune compatibility, include blood group and HLA crossmatch, as Melissa will talk about for you. That's less of an issue today because if your kidney is not compatible with your intended recipient, we have the opportunity to utilize paired donation to find a kidney that will work for them and have their donor give to a different person who can accept that kidney. Next, please. Good physical health. People have to be able to undergo, a major operation. We do these with minimally invasive small incisions, but it's still giving an organ. It's still putting people through a major abdominal surgery, and I think it's important for them to know that. We really want to focus on psychological health. There have been, unfortunately, things like people who committed suicide after donating, and that's a tragedy for us. So we want to make sure that people are in a state that they can understand what they're doing and doing it with the best of intentions, and then have the support around them to get through it because, this is a process and this is a significant hit to anybody. And, Jody was remarkably strong from all of her, training and all of her road biking and stuff like that. But even doing that, it still put her down for, a few weeks to a couple of months. And I think that that's an important thing for people to understand. The good thing is long-term, people go back to doing all the activities that they want to do, and they go back to, having children if they're interested in having children and other things like that. So there's lots of things you can do on the other end, but it takes a process to go through this. And finally, we want to make sure that people have healthy lifestyles so that they can protect their new kidney or their single kidney. So we do encourage people to stop smoking, remain active, have a healthy diet and a weight, maintain regular primary care and follow-up plan. It's important to know we will follow people at our center for a minimum of 2 years, but we really want to make sure that they have a lifetime commitment to working with a primary care doctor or provider and going forward. Next. We're working on making this a more quantitative decision. I think when I started, it was sort of a gestalt, and by looking at large databases, we've been able to sort of give people some additional data. When we think about asking for a donor, we've been able to show people now that, people in their 60s and 70s can safely donate. Not every center will take them, and as this sort of slide shows, there are some 30-year-old donors that everybody would take without a thought. There are some donors that have substantial amounts of risks that nobody should really safely do a donor because that puts them at risk. And that yellow zone in the middle is really where the center and the patient could have come together to figure out how both of our thresholds work, to understand that. Next. Um, how do we figure that out? Well, there are some basic demographic variables that aggregate the risks, the lifetime risk of going into kidney failure. So, if you have a family history of kidney disease, if you have, you're older, race continues to be an issue, not because of race itself, but because of the comorbid conditions that often accompany people of different ethnic backgrounds, as well as different genetics. We know that the APOL1 genotype tends to run more commonly in people of sub-Saharan African descent. And if you have both copies of that gene, your chances of going into kidney failure yourself are substantially higher. And that would automatically raise your risk, regardless of the fact that you're a 25-year-old otherwise healthy person with no hypertension. Then there's some risk-related characteristics. What are your current kidney function, your blood pressure, and that sort of stuff. And then there's some other things that are associated with what's the risk of the donation itself. How well will you do with losing half of your kidney? And this sort of shows that those vary by individual. And we're trying through the evaluation process to give people a very comprehensive understanding of that. And I think when you're talking about asking for a kidney, you can assure people that what we're doing with the people that they are asking to come forward is making sure that person is going to be as safe as we can. We know that every donation has a small but not zero risk to the potential donor, but we do everything we can to make sure that that is as minimal as possible. And I think many recipients want to know that to make sure that they're not asking people to do something that puts that loved one of theirs or person that they care about at risk. Next. There are some exclusion criteria, that make it impossible for us to do donors. So we don't use people under the age of 18 or who can't make a good decision. If you have uncontrolled hypertension that's caused end organ damage, so you already have damage to your kidneys from high blood pressure, you can't donate one of those kidneys because you're yourself at risk. If you have uncompleted or incompleted treatment of cancer, if you have HIV, if you have actively treated diabetes, pre-diabetes can be considered in appropriate cases, especially with weight loss. If we're concerned that there's coercion, so, people are feeling like, they're not making their own decisions. It is illegal to pay for a donor in this country. We certainly can make people financially whole by reimbursing wages and costs of the donation and that sort of stuff. But you're not allowed to, as a living donor, accept direct payment for your organ. And if we learn of that, we have to decline that potential donor. And diagnosable psychological or psychiatric conditions have to have mental stability, and any evidence of suicidality is something that we take very seriously. Click, please. So what's not defined in policy is how low your kidney function can be, how much obesity can you have, what your metabolic risk factors are, whether you're a smoker, and that assessment of mental health. And that's some gray areas, and that depends on what center you're going to. And I think that's where we're trying to, present to donors a really comprehensive assessment of their risk that incorporates all these kinds of factors. And so if you've got a history of high blood pressure in your family and obesity in your family and other metabolic risk factors, and you're a current smoker, that looks different than somebody who comes from somebody who's never had kidney disease, whose weight is normal and that sort of stuff, but is still smoking a few times. And so we help people to sort through those as best we can and that sort of stuff. Next. This is a picture of actually Jody's kidneys. She allowed me to show these to you. So this is the comprehensive look that we get. So we have a very good idea of what the anatomy of the kidney is, whether they have one artery or two arteries and that sort of stuff, and how the size compares to make sure that we leave the person who's donating with the larger, healthier kidney. So we always take the one, if there's a choice, we will try to take the left kidney, but if the left kidney is bigger, or that's going to put the donor at risk, we will take the other kidney. Next. The surgery is done under general anesthesia. Generally takes about 2 to 4 hours. It's done minimally invasively, either laparoscopically or robotically. Either way, they're small incisions. Most people are here in the hospital for about 1 to 2 days. We do a nerve block right at the end of the case to make sure people are as comfortable as we can and minimize the need for narcotics and other things that will slow down bowel function. Generally, 4 weeks off work, no driving for 2 weeks, and caregiver support for 2 weeks. And that doesn't necessarily mean 24 hours a day, every single minute, but it does mean you need somebody around, for the majority of the time, because you can't do laundry and you do groceries, and you're not going to be feeling up to snuff, at least for those first couple of weeks. And we do need to make sure that people are safe doing that. Next. The surgical risks, we are pretty minimal. This was a national study that we published looking at that. And the one thing that I think is an issue is that there is a potential risk for folks that are obese of higher rates of complications. And so, while in general people do okay, we found that certainly setting a BMI threshold of about 30 to 32 is a safe way for us to protect donors and minimize their complications. The other risks are things like bleeding, which is very uncommon, infections, damage things we're operating around, strokes, heart attack. Have there been reported living donor or kidney deaths? There have. If you look at the most recent numbers, I usually quote about 1 to 3 in 100,000 donors who've died with the current approach to this. Next, please. All right. If you could switch back to the psychosocial evaluations, and while you're doing that, I don't know if there are any questions in the chat. I can't see it. Let's see. Has the executive order helped to increase living donor transplants? Not a ton. I think the best thing that's really been helping us for living donor transplants is the reduction of barriers to doing that, both financial and otherwise. You mentioned if a potential donor finds they have cancer, that the testing is not covered by the transplant. It's covered by the person's insurance. And if the person doesn't have insurance, that can be a problem. So we often make sure and tell people prior to starting the process, it's really important that they have their own health insurance, because if we find something and they don't have health insurance, it can be considered a pre-existing condition. With the sort of Affordable Care Act protections now, that isn't as big a deal. But if the Affordable Care Act protections go away, and Jody's lights for the holidays are falling down. I don't even know what to say about that. Maybe there's if the Affordable Care Act provisions go away and the sky falls like the lights, it is going to be an issue for us. So we really do think that most donors should have their own healthcare coverage to make sure they can get coverage in the future. Any other questions in the chat for the surgery standpoint? Otherwise, I may have to exit in just a couple of minutes, and I'll turn it over to Farmar Charming and really, I think, very important components of our evaluation. It's this psychosocial stuff that I think, people under-recognize the importance of, but is the thing that I worry most about in terms of our patients. We can get a lot of them through the surgical part of it. We want to make sure that people end up on the other day, at the end of the day, feeling very good about what they did. So,
Dr. Axelrod, can
yes, ma'am.
you share a little bit about, like, if somebody is a donor and down the line they develop kidney disease and need an organ transplant, kind of how does that work?
Absolutely. So that's a really important question, and one of the things that we do look at in this country, as long as you are a U.S. citizen, and I understand that's a very important distinction in this day and age. You are eligible for priority on the kidney transplant list, and so prior donors are among the top prioritized people on a transplant list in the country. So they generally don't have to go back on dialysis and that stuff. But they do have to be medically suitable. So if you donate and you're 75, you're not medically suitable, that's an issue. But the vast majority of the time, we can get these people safely transplanted. The good thing is it happens very infrequently. It's usually on the order of probably 10 to 20 people a year across the country that get transplanted. But the protection lasts forever. So if you donate when you're 25 and you develop kidney failure when you're 65, 40 years later, you still get that same priority. Other questions? Terrific. All right.
Right.
Thank you for the privilege of talking to you guys. I'm sorry I can't stay for longer, but I leave you in good hands with Melissa and Jody.
Thank you, doctor.
Okay, back to it, talking about the psychosocial assessment. Um, and so in some programs, I have been the person primarily doing the psychosocial assessment. In a lot of programs, it's the social worker who's doing this. But I'm just going to kind of review the things that that we are looking at when we're trying to determine if someone is appropriate to move forward with donation. And essentially, what I'm going to be doing is kind of covering all these different categories. If you want to go ahead and forward the slide, please. Thank you. So a lot of what I do when I am, assessing someone, not only am I asking a lot of questions of them in terms of their lifestyle habits, their psychological state, that the social history and the supports that they have around them. I also am trying to educate them and sort of prep them for what it would look like to live the rest of their life with a single kidney. So especially since I donated myself, I feel like I can really provide a lot better and more realistic information than I ever did before. Sometimes when I think about how cavalier I was in terms of, oh, you're going to be fine, you're going to get through this. Because the thing is that donors, when they come in and see you post-op, they're usually trying to put on their best face and don't necessarily want to act like they're complaining. But the truth is that this can be a rather challenging phase, and it is temporary, but it is difficult, and it can be a real surprise for donors going through. So when I'm looking at their lifestyle habits, I'm looking at diet and exercise, what they're doing in terms of managing any kind of chronic issues, and looking at tobacco, alcohol, and other substance use. Typically, what we're doing is trying to remind them, like, we need you not to be putting a lot of weight on in the future. If it would put you at risk for diabetes, for instance, that's not a good situation for you having a single kidney. When I'm considering any kind of chronic pain situation, people inevitably end up going through times when they have pain. After donating a kidney, we're asking them not to use any kind of NSAIDs. And so for someone who has chronic headaches or migraines or whatever, if they've been managing that with Advil or other products that have ibuprofen, I will actually suggest to them they take a breather on this, see if they can manage their discomfort or pain with Tylenol, and then let us know if this is going to be a feasible thing to do for the rest of their lives. So, and then in terms of, smoking, alcohol, people can drink safely following donation. We want to keep it to a minimum, definitely within what's considered safe for human adults. And of course, those recommendations keep changing. So, it definitely want to keep men at least 14 drinks or less a week, and they really would be better off with less. For women, it's been 7 drinks a week or less. We have some people come in and say that they're using marijuana, that kind of stuff. It's not, contraindication for donation. If someone were using heavier substances, typically what we're looking for is a period of like 5 years of sobriety from all of that to make sure. And then, of course, we're still looking at all of their liver labs and things like that to make sure that any prior heavy alcohol use or drug use hasn't affected, their own kidney function and liver function and that sort of thing. When I'm inquiring about their coping strategies, I'm trying to get a really full picture of, have they ever been diagnosed with any kind of psychological condition? It is, again, not a contraindication if someone has bipolar disorder, anxiety disorders, depression, but we want to make sure that they are very well managed and stable. So those are the kinds of, this gets to be a very personal kind of interaction that I'm having with potential donors, but it's really important for us to understand how they go through any kind of stressful situation, because the donor surgery is stressful for sure. So another thing that I'm trying to figure out is, what will you do with your time while you are recovering from the surgery? It's, I do speak from personal experience. I had been active in CrossFit right up until the day I donated. And to go from that kind of level of activity to 6 or 8 weeks of just maybe being able to walk around the block or whatever, it's a very drastic change. And so, for people who rely on activity and doing that kind of thing as part of how they keep their spirits up, you really do need to be planful and figure out how you're going to spend that time when you're a lot more sedentary. Next slide, please. Okay, so then we're looking at caregiving needs. People are not allowed to drive for a couple of weeks following the surgery. So that's the biggest issue, really, is that if you have to come back in for a doctor's appointment, if, prescriptions or anything need to be picked up, someone else has to do that for you. And then, just doing things around the house. The simplest things that you don't really think about, but wet laundry is very heavy. So, I actually was in a situation where I lived alone when I donated, and I had people that stayed with me, but also had to work, and I was fine spending several hours a day on my own. But I was trying to get creative and do things for myself, and I kicked the laundry down the stairs instead of carrying a basket, and then like you're picking things up piece by piece. It gets to be really a bit frustrating, but you can find your workarounds. It is really good to have someone else there who can do those kinds of things and do the cooking and all of that. I did want to bring up the fact that you really don't need 24/7. And I know that we do kind of impress on donors that we want someone who's at least available for them, but it's not like you need assistance walking to the bathroom. We don't let people go home from the hospital unless they're able to safely walk to do things like that. And so you're also not usually requiring any kind of wound care. So it's not that you need like nursing assistance once you go home. Next. One of the things that we're looking at in terms of coercion is, whether a person is feeling either overt or some kinds of subtle pressure to become a donor. For instance, I suspect that there have been a few situations where we've come forward and it is possible that people are actually getting payment for what they're doing, or, we're doing everything that we can to make sure that, if it's a couple of friends that are coming in, that there's not anything that's untoward. As Dr. Axelrod had mentioned, there's nothing wrong with making sure that the person has wage compensation. And Melissa will talk about some of the programs that are now available. When I think about this, I think about when I started doing these, 20 years ago. There were not a lot of programs, either state or federal, that were supporting donors. And so I did sometimes have some suspicions that people were on the recipient side were paying for things for the donor. And I don't even really disagree with that, but it is true that you cannot pay for an organ. I remember a situation where, gave me a second pause. It was a young guy who was trying to donate a kidney to his grandfather. And this family, they were all involved in a family business. And basically the grandfather had told him, if you do this for me, you will inherit the business. that's coercion. And so, you know, you have to, even though you understand where the grandfather would be coming from with that, even, you know, I want to gift something to you because of this amazing gift you're giving me. Those are concerning. I recently evaluated someone who had some pretty serious legal issues that had affected his family's impression of him. And he was trying to donate, I think, to sort of repair his image with them. And I, again, understand the impulse. And, but, you know, we had to say no to him because of the motivation to do this is not appropriate. And the truth is that, you know, people can be living donors and you don't necessarily get all of that response back like, oh, you're such a wonderful person. And, you know, being a living donor, um, it doesn't make you feel like a wonderful person. I mean, I will tell you, it's like that's not the thing that kept me warm at night, or made me feel better when I was trying to deal with the recovery piece of this. I was so grateful that Jim was doing well, and that pleased me. But I don't sit around patting myself on the back thinking about like what a great person I am for having donated. Um, you know, and when you guys think about all of this, if you are a parent, if you're a spouse, do you wake up every day going, "Oh God, I'm so good. I am, you know, rocking this in my own life." So this is not something that you think about and, you know, wear as a badge of honor or whatever. I do try to do my evaluations of folks without anybody else in the room because I want to make sure that they are honestly sharing with me their their impressions, concerns, their thoughts, and their motivations. Next. So I will briefly run over some of this because it was sort of interesting. Years ago, there was a huge consortium that was developed. It was 10 different transplant centers. At times, it was up to like 12 or 13. What we were doing was, you know, enrolling potential living donors in this study where they agreed to have, you know, like a 2-year follow-up. We were asking all kinds of questions about, you know, their experience of living donation in terms of, you know, psychologically, financially, their pain. They were also looking at different biomarkers too. So go ahead for the next one. There was 193 people that we were able to follow for 2 years. It was pretty impressive. Now, again, this was at a time when there was less support for living donation. So this might change if we were to repeat this study today. I think we started around like 2011. But there were significant direct costs that were paid for donors, and you know it's the kind of stuff that, as Dr. Axelrod mentioned, it's the recipient, their insurance that pays for the surgery itself. But you know, you think about the travel to get to the transplant center, and people are coming in for pre-evaluation testing and things, so they're oftentimes making more than one trip to the hospital. That's, you know, gas money. It's the money that you pay to stay in a hotel if that's what you're doing, and food and all of that. And then there's just, you know, a lot of other sort of practical items that I'm often recommending that people get. A lot of times people get waist binders, and they sometimes will get these special pillows to help them sleep in a more upright position at home because of the discomfort all through your core that remains for a number of weeks. And also, you know, in terms of lost wages, at the time that we did this, you know, it was significant. 36 hours. I mean, it's almost a full work week of lost wages that they were experiencing. I feel very fortunate because the University of Iowa, the state of Iowa at that time, and still do, paid 6 weeks paid time off that didn't count against any of your own built-up PTO. So that was pretty amazing. But I wish all states were doing that. But again, you have to be a state employee to even qualify for that. In terms of mood, in this study, 20% actually reported moderate to severe mood disturbance at one of the checkpoints following donation. You know, I definitely experienced this. I was in a funk. It's a crazy thing to know that, you know, you go into the super healthy, you know, you're going to wake up with surgical pain and that sort of thing, but it's a different thing, the reality to live it. And I started feeling kind of down because I wasn't in my normal activity, and I just started thinking, like, what have I done? I mean, did I make a mistake here? These are all really normal thoughts that a lot of times people don't talk about. And there's, I think, some embarrassment about bringing up those kinds of issues. It's not that you do this and then immediately regret it. It's more like, have I done the right thing when you're living the reality of it? Next slide, please. Um, there's some body image issues. I mean, these kinds of surgeries don't leave a lot of, disfiguration, but definitely there's a ton of bloating that you have in your lower abdomen that remains for a long time. And so I try to caution people, it seems to be a little bit more of a female conscientiousness that, like, you need to, in fact, a lot of times people will wear just kind of like binding underwear for a while because it's uncomfortable. You are just kind of swollen down there. Um, Very few people expressed ultimate regret about having done this. Fatigue is a very common phenomenon, and I know that for months afterwards, I still felt like at times I just would get so gassed and without explanation. So that's a reality, and a lot of times people experience that for at least like the first year. I think that might be the last slide. Next, please. Yep. Okay. So I'm going to let you forward through all the ones that Dr. Axelrod had covered, and turning this over to Melissa now.
All right. Oh, I'm back. Back like I think 2 slides. All right. So one of the things we just want to start off with and everything is, removing those barriers to for living donation. The first one we want to talk about is like the financial aspect of it. Concerns that living donors may have that there might be some financial burden, when it comes to lost wages, childcare costs, travel, housing. And there are programs that we'll go over on the next slide that do help alleviate some of that burden. Another question we get, like when donors come through, is what if am I a match? And as touch based by Dr. Axelrod, there are times and stuff that somebody is not a match when it comes to blood typing not being compatible or the DNA typing not being compatible. And we have what's called that kidney paired donation program that we will go over too. And then next is just the knowledge, like how to get your story out there. Next slide. So there are programs out there that try to help protect our donors financially. The first one that I'm just going to go over is the National Living Donor Assistance Program. Now, this program offers up to $6,000 for paid certain expenses when it comes for both donors and the caregivers. And they help with paying for like the trips for evaluation, surgery, and medical follow-up costs. The next one is Donor Shield. Now they offer to pay up to $2,000 per week for lost wages for 12 weeks. And then also too, similar to the NALDAC, they offer up to $6,000 to cover for childcare costs, transportation, certain things like that. In addition to that, Donor Shield does offer an added protection if you donate through the National Kidney Registry. As stated, when you donate, you do get that protection of priority on the deceased donor waiting list, but also too through the National Living Donor Kidney Registry that you also get priority for a living donor kidney as well if you were to need one. They offer what's called remote donation through them, and that allows a donor to donate locally for their workup and surgery if they're looking to, say, donate to a recipient somewhere else. And then also with that, they do offer what do you call it? Mentorship. So they have donors that are involved in stuff that, if you have questions, they'll hook you up with one of their donor mentors who have donated to, if you have questions, that they'll walk you through the process. And then there's the AST. Jody, if you want to about that one.
Sure. So yeah, the American Society for Transplant has a couple of different things that they're able to offer to help support donors. This emblem is for the Living Donor Circle of Excellence, which is something that they do to recognize companies, corporations that support living donations. So they try to, elevate those companies, provide them more publicity, and celebrate the fact that they are willing to support living donors, like with wage compensation and things like that for time off. And then additionally, within the AST, there's also the Living Donor community of practice that I'm actually part of. But the AST actually has these really awesome things that are available to anyone. And so you guys, you can look. It's I think it's ast.org is the actual website, but they have created like a living donor toolkit, so that it provides a lot of education and information for potential donors and donor families, just to sort of figure out how they can support this person going through living donations. So there are a lot of resources out there intended to provide just support and information for anyone who is contemplating this.
Thank you. Next slide. So we talked about when it's blood type not compatible or DNA type not compatible. So this paired donation program is when we have incompatible pairs, and what we do is enroll them into this National Kidney Registry to find a compatible pair that match to them. So what ends up happening is that the two donors of wherever it is will end up swapping kidneys in order to get their recipients transplanted. With this is allowing multiple individuals that option of getting a living donor kidney as well. Next slide. And then how to find a donor. Different ways that you can do so is one, as a recipient, you can ask someone directly, whether it be friends, family members, anyone in the community, having that personal conversation with them. Next, you can write a letter or an email. This allows you to really tell your story on a personal level and to share that with individuals as well. When we talk about social media, a lot of people, it's a big one that we get stories out there, things going viral. But people can share, their story online. And then from there, friends and family can share that to get the word out there about the recipient's story about needing a kidney. And next, when we talk about microsites, we'll go over that in the next slide. Next is if a friend or family member, you can have them become what we call a donor champion. This individual becomes like a point person, that is your advocate, wanting to get you transplanted, to educate on the process, and to guide them to the transplant center about the organ donation process. So basically, you're a cheerleader on trying to get that living donor for you. And then to provide contact information for the transplant center. So there are business cards that we give out, for our individuals, for recipients, that they can hand out to anyone that's interested in being a part of the process to become a living donor. Do note too and stuff that this can be anonymous. Not all donors want to be known. And for that and everything, the whole process of what we do can remain anonymous if you choose to do so. And then you can reach out to the community, if you're involved in church or a support group or, writing to the newspaper, certain things like that, those individuals, it's just telling your story, will touch somebody in the community and they'll reach out to apply. And then lastly, you can ask to be a part of a fundraiser or a donor awareness function. Next slide. And then there's also two programs out there that help increase awareness. The first one is that we can talk about is the Big Ask Big Give. Now, this is facilitated through the National Kidney Foundation, And what it is a chance to hear from transplant professionals, from donors, from the recipients itself, about their experience of what they've gone through. And, they provide resources of how to take the next steps in their journey. The Champion Microsite programs, now this is facilitated through the National Kidney Registry, and what it is a free personalized website to help get your story out there. It is very easy for us to sign up here at university hospitals. We just enter some basic information in, and they'll send you an invite. And from there, once you get that starter site up and running, you will get 200 free business cards that'll have your name, your personal URL code that you can hand out to individuals as well. On that startup site, you can actually take it a step further and personalize it. Tell your story. How did you find out that you found out that you had chronic kidney disease and suddenly you need a transplant? And then what that gift of life would give back to you. It's telling your story is what's going to inspire someone, to want to step forward to donate. And then with that too, having that website is just another avenue of actually being able to share it. So you don't have to verbally tell your story over and over again. You have that website where you can hand out that card to, and they can go and read about your story. So some people just don't, feel comfortable doing that. So, but it's just another avenue of getting your story out there. And lastly, as we talked about, was the donor champion, that friend or family member that, is a huge advocate for you, to get that transplant to happen. Next slide. So this photo is of a pair that we did for a daughter to her stepfather. That was actually a remote donation that we did, where she donated here, and then at MUSC in South Carolina, he got his transplant. So share your spare. Next slide. And if you're interested in becoming a living donor, you can register for UH at uh.donorscreen.org, or you can scan that QR code that'll take you to the online medical questionnaire that you can apply to be a donor. And that's it. Thank you. Any questions?
It doesn't look like there are any questions. If you do have a question, I encourage you to go ahead and put that in the question and answer section. I think this is really good information, just to be able to help patients to be able to look at the options that are available for um, living organ donation. The question I have here, and I'm going to pose this to you guys, is they're asking if they can get a copy of the slides. So I will have those emailed out to those on the call today, and we can send you the copy of the slides. This presentation is also being recorded, and we will send this out to all of today's participants as well. If there's any other questions, I encourage you to go ahead and please put them in the chat.
One thing that I would probably add to all of this is that in my experience, when I have been not just interviewing living donors, but actually potential recipients, I think there's a lot of misunderstanding for recipients about, what living donation is and is not. And so being able to help them understand what's involved with the living donation process is enormous. So, I've even had people, come forward and say, well, I don't want them to have a shorter life because of this. That does not happen. So one of the best things that people can do when they're looking for a living donor is if we all can educate the potential recipients so that they can be slightly more informed when they are letting people in their lives know what's involved with this. And also to be able to reassure them that the living donor team does a very thorough medical and psychological assessment of these folks so that we would never allow anyone to donate if it wasn't safe to do so.
Yeah, and to add on to that, just with that information is that, if a recipient does have all these questions about living donation, they're trying to answer for their donor. We always guide them to just say, like, just give the transplant department a call, so we can answer accordingly.
So I have a question that popped up. It says, can a donor contact the shared donation center to register to be a donor, or is that done by the hospital if the donor wants to? So if you have a person who is looking for a donor, they live out of state, do they have to go directly to that recipient's hospital, or can they go to their local, hospital or to,
Yeah,
yeah.
so that we have, there's 3 different programs that are utilized for what's called like remote donation. I'm sorry, 2, which is there's a pair donation program and then the National Kidney Registry. And both of those, each center is different as far as how they're registered in. Like for here at University Hospitals, we are registered through the National Kidney Registry, and we do offer what's called remote donations. So if another center, say out in Mayo Clinic, Arizona, there's a recipient out there and their donors here, we can work them up locally, have the surgery here, and then ship that kidney to where it needs to go. So
I think the potential donor would probably need to still contact first the recipient center. Um, and if, and then kind of like sort it out from there, rather than just kind of like scattershot trying to find a center that would allow for remote donation. I mean, Melissa, don't you think it's like,
yeah, yeah, because when we get referrals that come through, say if we had a local donor, so they would probably apply, like we use our referrals through the National Kidney Registry. So if we get one, say if it's a donor that's trying to donate somewhere else, if they put that name in and it goes to like that other center, they'll contact us to let us know and stuff. Hey, we're sending that referral through. So there's
Thank you.
always like that open communication and everything, so we know where their donors and recipients are at.
I also want to share, so I think because of my blur on the camera, the Kidney Foundation of Ohio has the roadmap for kidney transplantation booklet that talks about the process that a patient goes through for kidney transplant workup, just that process. So, those of you in our service area, if you are interested, we can send these out to the social workers or nurses to be able to provide for their patients, especially those that are looking at the organ donation process, what that all looks like. So, um, and there is also a three-part video series that is available on our you can find it on our website or on our YouTube page that talks about the whole process of living, or I'm sorry, of organ donation. And it looks like one last question. What if a person wants to help but does not know the person needing the transplant? I had a transplant, and others asked me how to donate for shared programs where they do not know a person needing a kidney. So it sounds like an altruistic donor. Oh, you're muted, Melissa.
My only recommendation with that, it was just to like contact whatever center they may be interested in donating through, and then that living donor team will help with the next steps in the process to educate them on that.
Yeah. And have there been a lot of donors, 60 or 70-year-olds, that have been able to donate?
Yeah, we've had various ages throughout.
Mhm. Great. And I
So
would assume they try to match, like, if there's a 25-year-old needing a transplant, having a 70-year-old donor is probably not the best. Although
correct,
there are some 70-year-olds that may be much healthier than,
correct.
you know.
Yeah, and
So,
that's when we would like you to. So if we had that kind of situation where we had a very young individual that's a recipient, and then there's a much older individual that's a donor, where we may utilize that national, especially if that donor is approved, that we would utilize that kidney swap program to find a better age match for that younger individual.
great. Thank you. Well, we are out of time, so I appreciate the time that our friends from University Hospital were able to provide, giving us more insight on living organ donation. Um, Please, next month we will be doing a webinar on urinary tract infections in kidney transplant recipients. And so that will be on January 15th. Those of you who've registered for this webinar are also on our registration or on our mailing list, so you'll get information about that. And once again, after this webinar, there will be a survey that will go out, or there will be a link for an evaluation that will go out, and certificates will be emailed by the end of next week. And social workers, your Ohio social workers, your information will also be uploaded into CE Broker. So I hope you all have a good rest of the day, and thank you.
Thank you.
Thank you.